complications that we get into and how to manage them. Any comments from all? So, I don't know, have you ever torn your skirt flap? Because then what you do is you just yank off your skirt flap, partial thickness.
Do you get the kind of complications that I showed you? Do all of you get it? Dr. Das, like to make some comment on
what more complications that I have shown. But in due course of time, we'll learn how to manage them, and that is more important. You expect complications, but you must know how to manage them. That is more important.
Thank you. If there's no more comments, I think we'll go to the last talk. And that's very important because good surgery is only half of the job done, and a lot of things, as Dr. Parul told you, happen once the healing process starts. And then at what stage, how do we intervene, how do we manage these blebs in the post-operative period is actually very important for the outcome of fitting surgery. So Dr. Sushmita is going to tell us about how she manages the post-operative period.
Good morning. At the outset, thank you, Dr. Pandit sir, and thank you, AIOC, for this opportunity. Post-op management, TRAB is the easiest of the things that has been shown, and the problem comes later. So, completion of trabeculectomy surgery really is the beginning of a process that takes several months to complete. The alterations in bleb morphology and aqueous outflow due to the scarring response influences the long-term success, and appropriate management at the appropriate time is essential to ensure a filtering bleb, something like this, which we'd all like to see. So what is the ideal trabeculectomy? We'd all like to see a diffuse, mildly elevated bleb with normal conjunctival vasculature, visible fluid in the flap, and yet a scleral flap visible just at the base of it, a well-formed anterior chamber, a tightly closed conjunctival wound, and a patent sclerostomy. Now, isn't that a miracle to ask for? Because you're asking the body to heal completely, heal partially, and not heal at all. But this is the kind of bleb on the first post-op day which we all dream to have, and let's see what happens. But that's utopian. And all of us who do trabeculectomy surgery have these usual bugbears to take us through. So how often is follow-up required? I'm often asked this question because they say that every follow-up visit costs money. So that's a question which has been asked time and again. But then you can't get away from it. You do need frequent monitoring if you're going to do a trabeculectomy and you expect it to succeed. Because it allows changes in bleb characteristics to be identified, and there's an early window of opportunity which exists to modulate these changes. And if you lose this window of opportunity, you've lost the battle. So the first 6 to 8 weeks, we would say, are crucial in making your trabeculectomy bleb successful. So what our usual schedule is, we call them weekly for the first month, 2 weekly for another month, and then depending upon the bleb and the AIOC. So what is shown here is typically on the first post-operative day, you see it's a diffuse bleb all right, but there's a little bit of bleed, which really goes away by the time of the first week. At the end of 2 weeks, it's better, and 6 weeks later, you can be on your way to tell your patient that it looks as though your blebs are doing fine. But this entire period of time is not just wait and watch. This period of time envisages looking at the bleb and modulating changes as you see. So it's not going to be the same every time. But this is what a usual course would be, because we do very tight suturing. In the first week, there's going to be quite a bit of inflammation. So what you need to tackle is that. So frequent topical steroids and cycloplegics in the first week, and yes, you need to tell your patient that you will not be able to read from this side for the first month or so, because we are going to be using a lot of cycloplegics to bring down the inflammation and keep the anterior chamber intact. But usually on the first post-op day, the IOP is high because we've done very tight suturing of the scleral flap, because we don't want the hypotony. It's easier to manage high pressures post-operatively than low pressures. So what is usually required is a gentle massage, and I've shown it right there. You just need to go over the top lid, just beyond the scleral flap. So it's a sort of fish mouthing just for an instant. So you just give one quick massage, and that's usually enough. And this, you see, is a flattish looking bleb, and after the massage you can see the fluid. So this is just after, on the first post-op day. and it results in fish mouthing, and just one bead of aqueous comes out, and that's all that you need. So it's better to have intraocular pressure in the mid-teens in the early postoperative period and not have your eyes hypotenuse to prevent the secondary aqueous from coming and forming your anterior chamber, which is going to be rich in cytokines and the fibroblastic activity is going to be more. So be careful not to shallow the AC. So be very, very gentle with your massage. You can give 1 or 2 if you want, but just be gentle. Now, within the first postoperative week, usually the bleb is quite vascular. If it's excessively corkscrewed or inflamed, a subconjunctival 5-fluorouracil injection is given under aseptic conditions. So this is probably within the first week, and that's where the injection is given, way away from the bleb, but be careful. There is a risk of injection 5-FU going into the eye if your eye is too hypotenuse and if you inject it fast. So be very, very, very gentle. Be right away from the bleb because you just want that 5-FU to percolate down in the area of your bleb, but you don't want it inside. Now this is something which I'm not proud to share, but it's happened. I was too fast probably, and this poor guy suddenly became white as I was injecting it, and your heart is in your mouth when you do something like that. You don't really know what to do. Somewhere in your brain thinks, oh God, now I'm going to land him into a keratoplasty. But this is 1 week later, and 6 weeks later, thankfully, he did clear. But it's very, very scary when it happens. So this is just to show you that you need to be very careful while doing these procedures. The other thing is when to manipulate sutures. Well, intraocular pressure is still high, or if there's a lot of pressure required for massage, it's best to do a reducible suture removal, and it's prudent to do it within the first 10 days to 2 weeks before the scleral flap starts scarring down, because then, if you remove it later, probably the suture might break, and then you're in trouble because then you need to use a laser or something to lysis. So we usually do it within the first 3 to 5 days when the pressure is really high. And it's easy, you just catch hold of this loop. All these blebs are Phoenix-based flap because that's what I usually do. But either of them, with the Limbus-based flap, they work extremely well. And then you just need to take a sterile forceps, put in a drop of paracaine, and just pull out the loop, and you're through. So this is what a typical course would be in young patients. Day 1, all we need to do is give lots and lots of steroids for the inflammation. By day 7, usually they've had their suture removals and their injection 5-FUs in place. And by day 21, these bit of corkscrewing the conjunctiva is already becoming normal and on its way to becoming a good bleb. Now what if the pressure is low? Now that is more troublesome than if the pressure is high. Look at the bleb. If it's high with a shallow AC, it's probably due to overfiltration. You need to initially give it just a good pressure patch, atropine, and if there is a lens and cornea touch, you need to reform the anterior chamber. But low with or without a shallow AC, look for a leak. That's most important. And as Dr. Mandya showed that conjunctival retraction on the post-operative period, do a Seedles, look for your leak, and the way to do the Seedles is not to put in a drop of fluorescein, but take a dry strip of fluorescein and just paint that area of the bleb, and then look for a leak. And if it's there, that needs to be sutured immediately. Of course, with all low ACs, look behind for a choroidal or a retinal detachment, because those are things which might be overlooked and could be causing your blood pressures. Now, trabeculectomy can be very frustrating. And I came across this wonderful study, really, published in the BGO, and I suggest all of you who are doing trabeculectomy should read it. But I'm putting it here. They looked at 119 trabeculectomies with a minimum of a year's follow-up. 78% required some form of bleb manipulation, which means that what we're doing is not wrong. 49% of blebs needed a massage on day 1. 49%, nearly half, required at least one suture removal by day 7. 31%, that's 1/3, required one 5-FU injection by the time it was 2 weeks. And 25%, which is 1/4, required at least one needling and 5-FU injection by an average of 43 days, which is about 6 weeks. So post-operative intervention is frequent after glaucoma surgery, and we can't get away from that. It requires an intensive post-operative follow-up. It's a labor-intensive undertaking. Doing the trabeculectomy is easy, but salvaging the trabeculectomy bleb is tough. IOP in the intervention group, in spite of all this, was always higher than in the group that did not require an intervention. So what should one look for? There are several indicators that point to a risk of bleb failure. One is, of course, excessive conjunctival injection. If it's very, very red, you need to be a little worried. Corkscrewing of vessels, as Parul said. The corkscrewing vessels on the surface just means that the fibrosis is occurring just below the conjunctival surface. And those fibroses are pulling those vessels, which should have been straight, and that's why you need to be worried. Because you need to intervene right then, make those fibroblasts go away, so that that scarring can be reversed. And it can be reversed only in the first early post-operative period. If there's a high blood phase, it's important to recognize that, and that occurs if your pressures are high. If your pressures are high, ask yourself why. Don't just go in and accept it, and don't just do a knee-jerk reaction and put in a timolol or put in an anti-glaucoma agent. Ask yourself, why should your pressure be rising after the bleb? It's important to recognize a high bleb phase, which typically happens at 6 weeks, and conversely requires an aqueous suppressant to tide over that period and prevent it going into a Denon cyst. If there's flattening of the bleb, there's inadequate filtration, consider needles. And if the IOP is still high, do a gonioscopy, look at your sclerostomy. Many times you would have something blocking the sclerostomy. That's one iris pillar blocking it, half of it is patent. But you must look at the cause of what is happening, only then you can intervene in time. So in summary, the trabeculectomy is the beginning of a process aimed at achieving a satisfactory bleb morphology and satisfactory intraocular pressure control. But for some trabeculectomies, the post-operative period may involve many interventions. Each of the various interventions has a specific role, either in isolation or in combination. Recognition of bleb morphology is the basis of intervening in time, but it's a sobering fact that despite close monitoring, some trabeculectomies ultimately will fail. Thank you.
Thank you, Dr. Sushmita, dealing with I think, a difficult period in trabeculectomy. A lot of things actually go wrong with this period, and it's very important to monitor and manage them appropriately to have good results. We are actually just at the end of our time, but I think this hall is kind of not occupied for the next session, so we'll let you have a few minutes for questions.
Can I ask you a question?
Yes, sure.
I'm Dr. Sunil Gupta from Jaipur. I've seen some surgeons not using conjunctival sutures at the end of surgery. I'm just putting a subconjunctival injection, so that at first post-op, when we see it overlaps the bleb image. And another thing, I want to know the opinion of the house about using the mitomycin drops. Mitomycin drops post-operatively, how effective they are, or how they can be used.
I think the first one I didn't really get because the trabeculectomy, the wound is too large actually to heal like that. And, you might get away with it in a few cases, but more likely you'll end up with leakage from that area and hypertrophy. So I would not really suggest that should happen. I've never done it, not actually seen anyone doing it too. So I'm not sure how it goes post-operatively. And the other thing was the mitomycin C drops. I think mitomycin C is best used on table, and the drops are not really recommended because they have more systemic absorption rather than ocular absorption. And mitomycin we need in a very localized area, a little beyond the bleb actually, sparing the limbal stem cells. And if you're putting drops, you are exposing everything, and including your nasolacrimal acid and systemic absorption. So I think that should avoid. Other people, I think corneal surgeons, sometimes they use for optometry and other things, but I don't think that's a good way to do corneal surgery.
You also use only corneal suture when you combine it with the trial. I saw Dr. Nanga's video, he had put an inferior corneal suture.
Yes.
So how effective is that?
Yes.
It's not a problem. Just like you saw the superior corneal suture, you just put in an inferior corneal suture. And of course, you have the ability to draw down the eye as much as you want. So you just do it just a little bit, just to give you sufficient adequate exposure, so that when you're doing combined surgery, you don't get any distortion of the cornea and things like that. Because you need a clear cornea and you need to be able to see well to do your phaco and stuff like that. Actually. But it's not a problem because it gives you that additional amount of leeway to be able to access the sclera, make a proper flap, and things like that.
So you apply your inferior or superior corneal suture?
Superior. Most of
combined surgeries also?
Yeah, even a combined, because I do a separate size combined surgery, like separate side combined surgery. So phaco and trap in a different side. So if I'm doing traps purely, I do phaco on the temporal side. So there's no problem with the spiral conic suture.
At our center, we stopped doing two sides with the idea that if you want to do massage, so the corneal wound which you have made, will you suture that wound always or you just hydrate and leave?
Then you have to, if you had a good flap, if you have a good flap and if the apposition is good, you don't put a suture. It's not really required. But if your, the spiral tunnel for the phaco is not good, it's always safer to suture. Because you will need manipulation of the grafts post-operatively. So that's kind of, you should always assume that you need it. Because majority will need it.
Another thing, it was very nice to see you leaving a little of conjunctiva at the limbus.
Yes, a little ring, yeah.
Can you just explain on that how much we should leave and
just about half to 1 millimeter, very little thing. At the limbus, the two conjunctiva and the tendons, they are fused. They are kind of a single layer, different to separate. So go to the point there, beyond that they are kind of a separate layers. So just the second.
But in the end of suturing the same, we take the fistula and
yes, you take the wing sutures, pass through that fistula and make it really tight. But the edge should remain. It should not invert. So if the edge gets inverted, then they'll not be bleeding. So make sure that edge remains there. You can also put sutures, there running sutures on it around body needles. So make sure. But problem is that the needle tracks, they also leak sometimes post-operatively. So I think I most of the time I just leave it that way.
Last one for Dr. Nangia. I saw your vitreous tap, that shallow AC.
Yes, yes.
How much of vitreous do you tap and where
if you get just 0.1 to 0.2 ml, it's just fine.
And what is the location? How much pars plana you go?
Yeah, you always have to go to the pars plana. So you measure, 3.5 millimeter in a phakic eye, and then you just go in about 7 to 8 millimeter.
I saw you doing near the flap. It was just posterior to the flap and
yes,
this area.
Yes, because then otherwise, if you go there, that area is already exposed. Otherwise, if you take a different side, then you have to cut the conjunctiva or extend the conjunctiva, which is something that you don't want to do because the conjunctiva is very precious for the trabecular.
How easy is it to tap the vitreous? Because what we have tried our places, we do go from the separating season, pars plana, away, make a subconjunctival opening, do go with the cutter, cut some vitreous and come out.
It's no problems, of course we presented these papers and we came in for criticisms that, why are you using the needle? But if you go back to what Chandler and Grant used to do many, many years ago, they taught the whole world how to relieve malignant glaucoma by doing exactly what I showed you actually.
But I think that time we didn't have good cutters, so we don't have
yes, you're completely valid, but it is so simple. It is so quick actually.
Yeah.
Then we have maybe about, I don't know how many, maybe 60, 70 patients that we've done like this. In one patient, we had vitreous hemorrhage that did not resolve till about 2 months, and then it resolved. And that was not, maybe that eye was a little different actually, because in all the other patients, we've not had any complications and we have a long follow-up actually. So of course, I knew that every time I talk about this in front of an audience, there is a great possibility of coming for criticism, but I wish to assure you it is safe. And also remember, you would not know how many times the vitreous cutters are going to be used actually. People use vitreous cutters from a minimum of 5 times to a maximum of 12 times actually. And I don't know whether it is better to go in with a needle and do a controlled aspiration, or whether it is better to use a cutter for the 10th time and go and do surgery.
Thank you. Thanks a lot.
Thank you so much.
So for this needling, for the needling, can we, firstly the injection, instead of 5-FU, can we give mitomycin?
I think, mitomycin usually is better. You need to remove it because it stays for in the tissue forever actually, because it's really binds strongly with the brain. So if you leave mitomycin there, it's going to be there. People have used very low concentrations of mitomycin C, but 5-FU is what generally recommended for needling, and that's what I believe in.
Never ever use mitomycin for needling actually. It is completely contraindicated and can lead to amazing complications actually. It's better to use 5-FU or Avastin or whatever it is that you want to choose.
So mitomycin has very long-term effects and it can lead to spill necrosis at neck, and then that will be very hard to deal with.
And needling, do you go below the flap also to open the flap, or
Yes.
just sub
Yes, it is a difficult procedure initially, but if you've done the surgery and you know where the flap is, then you have to find the edge of the flap and go through the edge of the flap, and if possible lift up the flap, and also ensure that the tip of the needle goes through the sclerostomy opening that you have created. And when you move the needle like this, then you know that you got it through the right, because if you go through any other place, then the needle will not move like this, like a pendulum actually. But when you go through the opening that you created, because the opening was reasonably big, whatever the trabeclectomy opening, you can see the needle moving freely. So if you do that, then that is much better.
Last question.
So, do you combine origin with mitomycin?
No. Because the indications would be different. I mean, mitomycin you want to use where you expect a lot of scarring or when the tissue is thin in young patients. Origin I use when relatively there is profile is lower, or you want to use mitomycin C basically, like you have a thin connect, have a severe dry eye, your liver stem cell deficiency already, you want to expose that to mitomycin C. Or during pregnancy, suppose you're doing TRAB and you don't want to use mitomycin C during pregnancy, so you want to use origin. So indications are a bit different, so usually they're not combined.
Actually, he was pointing the question at me because he read that I use mitomycin and Ologen together actually. So I use my Ologen a little bit differently from what is recommended. I don't put Ologen over the area of the skeletal flap. I use it as a spacer and generally as something that may have some degree of anti-fibrotic activity. So it is placed generally to the left and above the bleb. Actually, it's not placed on the area of the bleb as is generally recommended. And we actually did about 35 such cases, both trabeclectomies as well as combined surgeries, and we did not have a problem in using both. Actually, there was no excessive, conjunctival melt or leakage or something like that. That didn't happen actually. But of course, the use of mitomycin, the way that we do it is very controlled. We use a piece of filter paper, either 8x4, 9x5, and we use just 2 drops of mitomycin, 0.4 milligrams, so that through capillary action they wet the filter paper. So the amount of mitomycin that we generally use is really very, very restricted, and it's all dose modulated. So, but no one, I don't know who else does this, but that's how I use both of them.
Thank you very much. I think we are almost.
Can you allow me one question?
Okay, the last one, please.
So you said you use the needling with Avastin. I just wanted to know what dosage you use and.
Just the normal, you just draw the. You need more Avastin when you're needling than you do when you do an intravitreal injection, because you're using it to create the bleb, and you're going under the skeletal flap, and also when you take the needle inside the anterior chamber, you inject a little bit in the anterior chamber.
You use it only for NVGs, or you use it anytime you
No, this is a needling that I did for a patient who didn't have neovascular glaucoma. That is, I do needling only with Avastin. In any case, post-trabeclectomy that requires needling, I do needling only with Avastin.
You do not use 5FU at all?
Well, I do use 5FU, but not for needling. I have mixed emotions about using 5FU, but in some patients we have used 5FU just at the conclusion of surgery. We have injected 5FU superiorly to the area of the bleb actually.
Is it because of lesser corneal complications with
Avastin?
Yeah.
With Avastin, there are no complications actually. There is no toxicity to the eye at all. Whether you inject it into the anterior chamber, whatever you do, you don't even come to know 1 hour later that you use Avastin.
Thank you, sir.
Okay, thank you very much for your interest and interactions. And with that, we close this session. Thank you all for coming, and thank you much. Thank you. Have a good day.
Thank you all very much.
No.
puncture, yak laser procedure.
Right, so can you please light? Yeah, well,
Can be performed along the combination with laser gonioplasty and synechotomy not later than 2 months after surgery in reference on elevated AIOC indices. Dynamic of tissue structure change after non-penetrating deep sclerotomy is presented in the next slide. Aqueous outflow pathway after trabecular disseminator membrane, gonial puncture 2 months later, and without gonial puncture 6 months later. Another choice of open-angle glaucoma surgery is implantation of express mini shunt. It is minimally invasive procedure with feature non-closing internal fistula. Features of surgical technique implantation of express are 27-30 needle for puncture and angle of 3-5 degrees from iris surface and cutting out of additional scleral groove. Note that the surgical technique secure an independent position of shunt in anterior chamber. You can see it in on sagittal scan and 3D images. Universal intervention in open angle and closed angle forms of glaucoma in microfistulation trabeculectomy with punch device used. At this slide, the biomacroscopy of filtration, web, and UBM scan is 3 functional zones of intervention: internal fistula, intrascleral cavity, and filtering lab. And the first day after different types of fistulation surgery are presented. Formation of outflow pathway is subject to the same rigors. In non, the remodeling outflow pathway after different types of fistulation procedure is observed during 6 months follow-up periods. So, normal formation at outflow pathway is visualized after non-penetration deep sclerotomy in combination with laser puncture. 3 zones of intervention also show normal dynamics of intraocular aqueous outflow pathway formation after express implantation. After different types of fistulation surgery, the process of intraocular aqueous outflow pathway formation includes hemostasis and coagulation of blood, inflammation, migration of fibroblasts, formation of extracellular matrix, and scar remodeling. The process takes up to months or more in the norm. Hyperscaling of aqueous outflow pathway is a common problem with fistulation surgery. At the images, their fibrinosis exudate in intrascleral channel and filtering lab in 2 months after non-penetrating deep sclerosis. Without treatment, the inflammation results in surgical failure and IOP decompensation. Control of post-operative outflow pathway status is a result by methods of biomicroscopy, gonioscopy, and UVA. Biomicroscopy exceeds filtering, lab condition, vascular injection, edema, response to transpalpebral massage. Gonioscopy estimates internal fistula condition and UVM evaluates a zone of intraocular aqueous outflow pathway. Monitoring the timely based rehabilitation allows precisely diagnosis the cause of outflow pathway failure and optimizing the process of its formation. Compare please the images of filtration lab before and after treatment. Disturbance of outflow in internal fistula zone occurs as a result of edema, fibrin, blocked by the iris. In the cases, the anti-inflammatory, hemolytic therapy, and laser iridoplasty and performed. Intrascleral channel state can be estimated indirectly by tracing lab condition of by ultrasound biomicroscopy data. Dysfunction of intrascleral channel requires a performance of following procedures: needling, injection, or intraoperative application of cytostatics, MMC, 5-fluorouracil, injection and angiogenesis inhibitor, anti-VEGF, and transpalpebral massage. Condition of filtration lab depends reliability of internal fistula and intrascleral channel, the isolated inflammation and encapsulation of filtering lab may occur. In case of excuse vascularization and edema of filtering lab requires needling with glucocorticoids, inhibitors of angiogenesis, anti-VEGF. In encapsulated filtering labs and ring-shaped scar requires a needling in combination with glucocorticoid and 5-torpilins. Remodeling of intraocular aqueous outflow pathway is only possible with pathogenically oriented methods of treatment. The tactics improve the efficiency of fistulizing surgery and decrease occurrence of unwanted outcomes. Thank you very much for your attention.
Thank you, Professor Shukru. I think the talk brought out two very important aspects of glaucoma surgery, and I think we talk a little bit about both of them. One is the efficacy of non-penetrating surgery versus a trabeculectomy, and the second one is that the surgery itself is only 50% of what is required, and 2 or 3 months of good follow-up is absolutely essential to get a good filtering.
Worked well in Indian eyes. So non-penetrating keratoplasty of any form is less likely to be more effective in Indian eyes. That is a great racial variation. But your experience is well taken up, and I think 90% is a very high success rate. Thank you.
I think non-penetrating glaucoma surgeries have been around now for almost 15 to 20 years, but they haven't really taken off as the standard of care. Dr. Pandit, do you have any other experience with the non-penetrating?
I had tried the non-penetrating printing surgery, but as Dr. Das said, I think we are not really very happy with the results.
What was the cause of failure in your eyes?
I think scarring basically.
Scarring at the conjunctival, subconjunctival or subscale?
And I think also that you needed the corneal puncture, and once you do that, it doesn't really open up the way it should in our eyes. So probably I attribute to the scarring of the flap which happens. So even after corneal puncture, the pressure doesn't really come down.
Are there any other people in the audience who have used a non-penetrating surgery? Dr. Mayuri?
I'm not sure.
You haven't used it. Okay, so I think basically what we found, this is what the studies we did in Delhi, but we did them almost 10 years ago, that our success rates, as Professor Das has said, were not very high at all. We found that almost all of them over a period of 6 months or so tended to fail. We were not doing the gonioplasties or the goniopuncture at that time. So I think subsequently when we did start doing the goniopuncture, we had the same problem as Dr. Pandav, that by then the subconjunctival fibrosis had already occurred. So even if we did the goniopuncture, we didn't get a good bleb. I think if we move on now to the second part of Dr. Shukur's talk, which was about how long it takes for the modeling and the remodeling of the bleb to occur, it occurs in about 2 months. So I see Dr. Shushmita coming in at the moment, but we'll go to her next. Dr. Pandav, how do you normally treat your patients post-trabeclectomy, which I presume is the most common surgery you're doing? There's another mic behind you.
Got it. Basically, you have to monitor the drugs very carefully, and when we do glaucoma surgery, we aim at a tight closure so that you don't have any post-operative flat ACs and hypertonia. That's the main concern after putting surgery, and it's good to have pressure maybe on the higher side, maybe low teens or even early 20s, because you can always bring it down by adjusting your sutures. So I always use the laser sutures, and I wait for a couple of days even if the pressure is high, just control medically. And when the time is right, that's about 3 to 5 days, when some amount of healing has started happening, and if you open one of the laser sutures, the echo is not going to run around that much, so you'll have a good diffuse bleb around that time. And then you see how much of the inflammation, you control the inflammation and make the bleb diffuse, and if you need 5-fluoro uracil, that between 7 days to 2 weeks time, that's the usual time, and a lot of vessels coming, a lot of fibrous tissue comes in. So at that time you need to use some anti-fibrosis agents, and also you need bleb massage at that time so that the bleb doesn't remain contained in a small space. So the more diffuse the bleb, the better it is. So that is how we go about it. There's no every patient has to be treated.
I presume you use some topical steroids. So how long would you advise the use of this topical steroid?
Typically for about 4 weeks. We start with the higher doses in the beginning, in the first 7 days, and then we reduce it. But we at least 4 to 6 weeks we need some sort of.
I think that's probably the average. I don't know if there anybody else in the audience who uses steroids or any other anti-fibroblastic or anti-inflammatory drug for less than 4 weeks. Would anybody else like to tell us their experience of how they manage patients? No? So, I think we agree that at least 6 weeks is what I would say you need the steroids for. The younger the patient, probably the longer you need to put it, because the children have a much greater inflammatory response.
And sometimes because if you use too many steroids, then there could be a steroid-induced component that comes in. So you kind of have to balance the two things. Yeah, but you do need anti-inflammatory agents, including cycloplegics. I use cycloplegics at least the first week after surgery. So that helps retain the imperial chamber and also reduce inflammation.
Which cycloplegic do you use?
Mostly homeopathy, most of it.
I think you'll find a great variation over there, because we tend to use tropicamide because it's short acting. It actually dilates the pupil and allows it to come back, so you don't form peripheral anterior synechia or posterior synechia. With HA and atropine, the pupil tends to remain in one place, so you have a tendency to go into synechia either way, either at the ostium or posterior synechia at the pupil.
When my idea of using cycloplegia is to have a cycloplegia rather than just dilation, because that relaxes the city body.
Propanomide has both. Propanomide has both.
Very short, actually.
Different treatment at individual.
Yeah, individual, absolutely.
Yes.
Dr. Mayuri, would you have any experience with the anti-VEGF treatment?
Excuse me, ma'am.
Yes, sorry.
You were talking about sanitary. How many sanitizer you have noticed in your patients?
We used to at one time use atropine and fomatropine. That was about, say, 20 years ago. And very often if we did a post-trabeculectomy gonioscopy, we would find that at least around the ostium we would find synechia. Not so much posterior at the pupil, but at the ostium you would find synechia. Especially in children, this was much it was almost, I would say, 75% of the time. So that's why we stopped using atropine. We then moved to fomatropine. But we still found that these ostial synechia continue.
Thank you.
Sir?
No, I've had some experience using anti-VEGF. We deliver it directly into the anterior chamber in cases of nucleosis iridis. And it really has helped me just doing a simple trabeculectomy. The results do last up to nearly 2 years. You may have to do,
So I think that's a different scenario altogether, because you're using the anti-VEGFs for decreasing the neovascularization.
Neovascularization.
But in a normal trabeculectomy for, say, open angle or angle closure
I
glaucoma.
don't think that has a role.
Yeah, I think people have done studies.
People have used it.
Yes, I think we've tried it as well, and applying it into the bleb or in the region of the bleb, but we didn't find any great use of it. So I think we'll go on to the next topic. The next speaker is Professor Chernik. And his talk is on prospects of the ultraviolet laser with a wavelength of 308 nanometers in glaucoma surgery.
Dear colleagues, I am glad to be here and see you all, and would be happy to share with you the results of our work. Clinical use of excimer laser with 308 nanometers wavelengths in glaucoma surgery. In excimer laser trabeculotomy method, excimer laser with wavelength of 308 nanometers influences the trabecula up and down. The main stages of ELT are shown on the slides. It has been demonstrated that ELT causes minimal signs of inflammation and lack of necrosis and fibrosis formation in the exposite area. The goal of our study was to develop safe, clinically effective and easy to use in clinical practice technology of glaucoma surgery with excimer laser. To reach the goal, first we determined the optimal excimer laser wavelength. Then we found easy to use method of emission delivery to surgical area and tested the method in clinical setting. Experimental part was carried out with scleral tissue of certain three wavelengths. (248, 308, and 353 nanometers, generated by three specially designed laser systems. For studied wavelengths, two characteristics were introduced: ablation threshold and speed. Ablation threshold was defined as the first visible under microscope effects of laser exposure. Decrease of scleral thickness in exposed area and subsidence of scleral surface. Ablation speed was defined as the ratio thickness of scleral layer evaporated in one impulse to energy density of excimer laser. 308 nanometers excimer laser has been shown to have intermediate ablation speed. We also studied ultraviolet rays penetration spectrum of sclera by spectrophotometer. As the curve shows, waves with less than 300 nanometers length significantly absorbed by superficial scleral layers. Penetration capacity gradually increases with wave lengthening. The curve shows the penetration spectrum of distilled water and balanced solution. Ultraviolet rays with wavelengths from 190 to 400 nanometers were studied. Wavelengths set we studied in range were absorption by balanced solution, substantially decreases and penetration spectrum increases. This means that under exposure of 308 nanometers wavelengths, intraocular fluid does not impede scleral ablation. We studied the effects of three excimer laser waves of different lengths. Two morphological structure of scleral tissue. We did not find any signs of coagulative damage and other pathological changes. As a result, 308 nanometers laser has been chosen for the following testing in clinical setting, because it is not absorbed by intraocular fluid, it does not go through sclera does not damage, providing high speed of ablation of scleral and trabecular tissues. The treatment is carried out in the surgical room. To deliver laser to the surgical field, we use flexible fiber, light guide, use easy to use handle. You have applied this technology in 14 patients. Their characteristics shown on the slide. The methodology of surgery is shown on the slide. The stages of laser separation of deep flap are represented here. The separation is performed with high impulse frequency. The next video shows scene of tissues by laser in filtrating zone. It is performed with less impulse frequency. As filtrated trabecular tissue evaporates and trabecular becomes thinner, the filtration increases. During the observation period, all patients reached stable decrease of intraocular pressure. Outflow tract is completely functioning, which result in stable visual functions. The next slide demonstrated the result of our glaucoma surgery method in certain patients. You can see the status of the angle of anterior chamber before and after the operation, as well as intraocular pressure changes. Here are the conclusions. Thank you for listening.
Thank you very much. Do you need to do a video culture after this? No. Okay. There is a mic. started using it, there are very few centers that actually use the excimer laser. Can you tell us some of the problems that occur with the excimer laser as used here? As compared to using a blade, what are the differences between using a blade and using an excimer laser?
We're talking about the clinical results of this study, and this is the trial study, experimental study, and during the all follow-up, 1 year follow-up, no severe complications we didn't see.
Thank you. So basically it just takes care of a lot of complications. You don't have to convert to a trabeculectomy. It's much safer. Right? But the efficacy in the long term we really are not sure of. Are there any other comments from the audience? I mean, has anybody seen any examiners being done? Any?
CO2 laser was there, no? That was also
Mike, did it?
The CO2 laser was also used for the canal of capacity. So how different the results are?
What is the difference between this excimer 302 versus the carbon dioxide laser, which used to do the same thing, that you could de-roof the canal of Schlemm without actually going through? So what is the difference between the carbon dioxide and this? Okay, so I think we've seen eximers go from going through the anterior chamber, trying to make small holes in the area of the trabecular meshwork, and now they've gone the other side. They're actually going ab externa and trying to do a non-penetrating glaucoma surgery. Thank you very much. Thank you. We have Professor Lebedev, who's going to talk to us on opportunities of increasing efficiency of non-penetrating deep sclerectomies. For all of us who don't actually do it, maybe this is an opportunity to learn how to do it better and maybe get a little bit more success. Because there are cases in whom you don't want to do trabeculectomy. You don't want to take the risk of having a shallow anterior chamber, of having macular edema, hypotony. So these are options that one should consider. But as I said, our results so far have not been good. Maybe we'll learn something from Professor Lebedev.
Hello, my name is Oleg Lebedev. I am professor of Omsk Medical University of Omsk, Russia. The topic of my presentation is opportunity of efficiency increasing in non-penetration deep sclerectomy. And second name of my presentation is full cut. Currently, it's possible to ensure IIP reduction by 50% or more against the initial level and reduce the daily IIP drop to the physiological level only using surgical techniques. The number of anti-glaucoma, hypertensive, anti-hypertensive operation is rather high. Google data 2 years ago, the number of the sources exceed 300,000. NPDs identification are quite numerous. Reduction of the surgery area, technique slowing the reparative regeneration process, improvement of the drain and UV-scleral outflow ways, drains. Which operation would you advise first to the patient with two-stage glaucoma? Opinion who was contacted. Replies: sinus trabeculectomy 60%, NPDs 47%, operated activation of UV-scleral outflow 28%. Conjunctival discussion is performed along the limbus at the distance of 0.5 to 1 millimeter from in with the length of 1.5 or 2 millimeter, and the interfacial scleral flap is cut with the size of 2.5 by 2.5 millimeter micro NPDs. During further research, the optimum size of the stripping zone of the trabecular membrane was justified using mathematical and clinical methods. Width 1.5 millimeter, length 2.5 millimeter. A small extent of inflammatory response and cicatrization process was proven. The method close to develop, one is the method of surgical treatment of open-angle glaucoma, according to which the bed of the deep scleral flap extends outside the interfacial scleral flap, which is attained by means of shortening of the interfacial scleral flap or excision of the deep scleral flap bed outside the interfacial scleral flap. What shall we do? Technique improvement or operation improvement? The first experience of observation of 177 eyes in 177 patients with primary open-angle glaucoma operated using standard NPDS method in the regional clinical ophthalmological hospital in 27 operations performed on more than 300 patients with an average observation time of 9.7 months. As the technique excision stage was not very much impressive. The operation efficiency was only 69%. The work objective is to improve the AIOC lateral operation, not penetration deep sterectomy, to reduce the zone of the excessive cicatrization after the surgical intervention. Material supports. The research was conducted on the eyes of 50 patients with a primary open glaucoma POAG. The patient's average age was 69 years. In 20 patients, the POAG was the initial stage. In another 20, developed. In 10 patients, 5 months. In this group of patients, non-penetration deep sclerectomy improved by out cells with a scleral interfacial scleral flap size of 4 by 5 mm was performed. The impedance methodology improved by out cells shall be performed as follows. Techniques. Dissection of interfacial scleral flap. 1 interfacial scleral flap. The interfacial scleral flap is dissected. Deep scleral flap is marked. 2 deep scleral flap. Formation of the scleral step and DCF bed. 3 scleral step. Formation of the scleral step and DCF bed with the draining system element stripping. 4 scleral spur. 5 filtration zone. The deep scleral flap is resected. The interfacial scleral flap is shortened. Free retention on the interfacial scleral flap. Control group. 50 years of patients with POG with PDS made as per the conventional methodology with the interfacial scleral flap size 4 by 5 mm. The average age was 68 years. In 20 patients, the POG was in initial stage. In another 20, developed. In 10 patients, 5 months. Complication. In both groups, there were no operative complications during interventions. In post-operative period, in each group, 1 case of detachment hernia was found, which were corrected surgically, or else clear connection. The intervention short-term results were evaluated by hypertensive effect through intraocular pressure P0, 1 week and 1 month after the operation, which turned out to be more pronounced in study group. In the control group of patients 1 week after the operation, the P0 was 40.3 mm, 1 month after the operation, 15.7 mm mercury. In the group where NPDS, as per the methodology improved by our cells, was performed, the P0 after 1 week was 10.1 mm mercury, after 1 month, 11 mm mercury. In the control group of patient 1 week after the operation, the overall efficiency was 91% and 1 month after the operation, 82%. In the group where NPDS, as per the methodology improved by our cells, was performed, the overall efficiency was 98% after 1 week and 97% after 1 month. Conclusion. According to the study, finds the improved NPDS option has a large hypertensive effect in short-term observation compared with the conventional operation methodology. This NPDS option is more appropriate in case of technical difficulties with the extraction of the drain system and the proximate membrane elements as well as in the insufficient filtration of the intraocular fluid through the trabecular and the cement membrane. Thank you.
Thank you, Professor. Dr. Sushmita, would you be using non-penetrating surgery in any patients that you do?
Considering that the efficacy of NPDS has been found to be equivalent to almost 25%, 30% reduction that we see with prostaglandins, and the ones in which we operate usually are the ones which we can't control medically. So in our practice, at least, we don't use NPDS as a mode of glaucoma surgery.
Is there anybody in the audience who does use NPDS for any kind of patients? And is there any reason you think why Indian eyes don't do so well with non-penetrating surgery, Dr. Pandey? Microphone देना जरा please. Mic देना.
Dr. Gauss is that because maybe there are national differences because NPDS has been done in Europe with Caucasian eyes and some results, and also like Russian studies there seems to be quite encouraging. But the data from this subcontinent is actually not there, and people who started using it here, they have sort of they're not using it now, so most of them are not really happy with the procedure. So there might be some ratio differences because the technique that we follow, at least I followed initially, was the same as our counterparts were using in Europe, basically. So I was not aware of the Russian work, but I did follow the European work, and our results were not really the same that they have shown. So there might be some racial differences because our eyes probably scar more, they react more, and we probably need more antifibrosis or something which we didn't try. We just used the standard procedure. Didn't work that way.
I think what it also does is the non-penetrating surgeries is saying that basically whatever there is or whatever resistance there is to outflow is outside the canal of Schlemm. So maybe we have a problem. Maybe our problem with the flow, especially in angle closure eyes, is probably within the canal of Schlemm. So maybe that's something that we should be looking at. I mean, there were many interesting studies many years ago by two Russians, one Dr. Krasnov and another one Dr. Nestorov. And both of them, what they did was they actually opened up the sclera sequentially. So they started off by shaving off the sclera in a particular area over the canal of Schlemm and waited to see when they could get the aqueous coming out. So what they found was that most of their studies, by the time they reached the canal of Schlemm, there was a lot of aqueous flowing. So they found that most of the reasons for the rise in intraocular pressure in the eyes that they studied was, as is described in most books, as being adjacent to the canal of Schlemm or outside the canal of Schlemm. While for us, when you have patients who have angle closure, you have a lot of inflammation inside the eye. Quite often when we do surgery, you find almost a kind of membrane. Once you've removed the sclera, you find a membrane sitting inside. So maybe that's one of the differences that we haven't actually figured out in our eyes where we find these changes. There were some histopathology studies that we have done recently, and we can actually show that in most of our eyes, even the primary open-angle glaucoma eyes, because the intraocular pressure that we see in an average open-angle glaucoma is probably 28 or 30 as compared to reports from Caucasian eyes. What is probably happening is that the trabecular meshwork is more damaged, more fused than it is in Caucasian eyes. But when I said this to somebody from England, they said you're not doing your non-penetrating properly, that's why you're not getting success. And what was suggested to me was that we don't go far enough into the clear cornea. So what I was told was that you must go at least 1 millimeter into the clear cornea. Then when you remove the roof of the canal of Schlemm, the efficacy will come. So we did go back and go 1 millimeter into the clear cornea, but unfortunately we still didn't get the success that has been described. So I think it's very interesting to see the old Russian studies and the new Russian studies, and see how well this particular surgeon